so I'll stand between you and lunch. What I'm going to do is I'm going to talk about two of my passions. One is this, and that's controlling liver metastatic disease. Those little black dots are melanoma dots within the liver. This is the other passion I have. My family would say it's actually an illness. And I'm going to talk a fair bit about cycling as well. Any cyclists here? So you'll have... Okay. So you'll have time to do some emails and stuff when we go through the cycling stuff, okay? So, what did I want to cover? I wanted to cover the biology and the natural history of the disease, to talk about what we know, and then look at some of the experience we've had, because the data is poor, as you know, and then think about treatment options for patients with liver metastatic disease. That's what I'm interested in. The important bit is to understand that, yes, malignant melanoma, yes, it's derived from a melanocyte, derived from the same cell, but the tumour biology is hugely different. So we should think of it as a completely separate disease. That melanoma tag is actually quite annoying in some ways. Cutaneous melanoma, you get a lump, you cut it out. So the vast, vast majority of cutaneous melanomas you remove. When they spread to lymph nodes. So if you have one on your leg, it'll go to your groin lymph nodes. When it goes beyond the groin lymph nodes with cutaneous melanoma, it can go anywhere in the body. Okay, so we see metastatic disease from cutaneous melanoma almost everywhere in the body. The pattern of disease with ocular melanoma, where the eyeball has no lymphatics, there are no lymph nodes, so those tumour cells go from the eye, go from the globe, and they spread to the liver, and they can sit there for years on end, and then they start to present themselves. So that presentation, we were saying that when the disease comes back, about 80% of people, it comes back within their liver. That's the organ it comes back in. And in a lot of patients, if you don't control that disease in the liver, that's the thing that leads to people's downfall. That leads to their becoming unwell and sadly to their demise. So we won't talk about the primary. We're going to talk about that later on. I always think the symptoms are a bit like a hangover. They're very vague. The good thing about the primary tumour is we've got lots of good evidence. So the collaborative groups in North America have looked at the different treatment options, and you've therefore got strong data to help you make that decision about which is the best treatment for me as an individual. And that's really helpful. To my reading of it, you're really just playing off the side effects, whether it's plaque, whether it's using one of these tantalum markers and proton beam or enucleation. What you're doing is you're looking at the side effects and complications of the primary treatment. Actually, in terms of the prognosis and the long-term chance of getting metastatic disease, it seems to be much more relevant looking at the cytogenetics, looking at the actual tumour itself. So thank you, Sarah and Bertel. I think he's gone to the US now, isn't he? They've helped us answer that question that everyone asks when they get that devastating news they've got cancer. What's the chance this is going to come back? What's the chance this is going to kill me? Those are the things people want to know. And actually, we have evidence for that. Now, the evidence is stronger if you have tissue, because you can put in some of those markers up at the top here. But you can demonstrate then the chance of this tumour coming back. Once you know the chance of the tumour coming back, the next question people will ask me, I'm a radiologist, is which is the best screening technique? And we've just had that discussion. So I have no doubt that MR is a much better screening test than ultrasound. There's no doubt about that. Now, can I point to a paper that shows you that? No, I can't. But any big liver centre in the UK, if you go to any specialist liver radiologist, they will tell you the same thing. Liver MR is undoubtedly the best test. Ultrasound's an inadequate test. Ultrasound's so dependent on who's doing it. That's the question. That's the issue. If it's delegated to someone who's just looking for the gallbladder and a few other bits of the liver, they're going to miss small volume disease. If they miss small volume disease, the chance of you getting cured or having long-term survival when you present with big disease is much less. So, what do I think? When people ask me which is the best screening test, these are two bald eagles. This guy here is cheating. He's got some Leica binoculars. Now, this guy's saying, yeah, you're cheating, mate. Well, actually, yeah, do cheat. So use the best bit of equipment that's available to you. The best equipment that's available to us is MR. The only caveat, the only thing we don't know is should you be using the MR contrast agents. Those are the things we inject into the vein, and they help us increase the sensitivity of the scan because healthy liver takes the contrast agent up, tumours don't. Now, the reality is, a few years ago, I'd have said you need the contrast agents. There's actually now the tools are getting so good, and there's special sequences we use that actually I think we're moving to an era where we'll probably use unenhanced, that's non-contrast enhanced MR as our screening test. We don't have strong evidence for that. Actually, we'll be able to use the evidence from other tumour types, from colon cancer, from breast cancer. It's just about detecting small lumps in livers. So, but MR is undoubtedly the best test. Now, I remember 6 years ago, the first Ocular conference, everyone was quite nihilistic about picking up liver mets because they said when you pick them up, we don't have good tools or good treatment options, so actually, does it matter if you're missing people early? And I think undoubtedly it does. I think the fact that if you look at the programme, we've got 5 oncologists all talking. The fact that no one has the answer shows that, yes, the primary tumour, we have good evidence, we know what to do with. Actually, when patients get metastatic disease, we're still in an era where we don't know the best treatment options and we don't have strong tools. And people say it's difficult to manage. Well, you'll have to indulge me for a second. So I'm from Southampton. We like things that are difficult. So this is last weekend. Anyone been to Ventoux? Ventoux's the beast of Provence. So it's a sort of cycling mecca, really. And this is Pantani. There's Lance Armstrong. Lance Armstrong was broken there. Froome had to run up there because he crashed a couple of years ago. And these are the really heroic guys. This is Tom Simpson. So Tom Simpson, he looks gaunt. He actually died about half an hour after that on the way up the mountain. So his memorial's there. That's his memorial. He was fueled on amphetamines and alcohol. We went there, so I went there with a professor of surgery last week for no good reason other than if you climb up and down it 3 times in a day, you join a club. There's a club in Paris. That's my heart rate, about 180 for 6 hours. You join a club of madmen. So the madmen of Ventoux, they're called. So we like things that are difficult, is what I'm saying. And just because something's difficult doesn't mean you shouldn't do it. Okay, so why have I got a job? What pays my mortgage? Well, this pays my mortgage, the plumbing of the liver. The liver's a unique organ. It has a big tube, that big tube there, the portal vein, with all the goodies coming back from your guts, with all the hormones, all the things you eat in it. And it has a fairly weedy little artery. So that's the liver artery there. The flow, relatively, is about 90% in the vein, 10% in the artery. So the liver artery is actually a small vessel. Tumours get their blood supply. Healthy liver is here, gets its blood supply from this half of the graph, from the portal vein. Tumours get their blood supply ubiquitously. They get it completely from the artery. So there is a vulnerability of tumours. The other thing is, when we talk about successful tumours are successful because they lay down new blood vessels. So when we talk about Avastin or the nib, sunitinib, sorafenib, we're talking about chemotherapy drugs, novel drugs, which are targeted at stopping tumours develop new blood vessels. So that is a weakness of tumours. So if you're going to be a successful tumour, you have to lay down new blood vessels. And of course, for me, that's great. You're laying down a target for me. This is what tumours look like when we get into someone's liver. So this is a liver artery. This is a liver here. These things that look a little bit like golf balls are tumours. And actually, this pattern of disease where you get discrete nodules is good news. These treat well. When you get this pattern, which is where there's diffuse tiny disease everywhere, what I call the measles, sadly, this pattern of disease treats poorly with either or any of the techniques I'm going to talk to you about. So, people say to me, which is the weapon? Which is our weapon of choice when we're treating with liver tumours? Well, there are 3 weapons that we use. There is TACE, which stands for transarterial, so through the artery, chemoembolization. Okay, I'm not sure which weapon it is, but that's one of them. Radioembolization, or SIRT, are the radioactive particles. So SIRT or SIRTEX is the company. And the last one we'll talk about is isolating the liver and giving it a massive dose of chemotherapy, and then clean the blood out before you give the blood back to the patient. So 3 different weapons: blocking blood vessels and chemo, radiation, or isolating the liver and big doses of chemotherapy. Now, this is just a schematic which will help explain how these different treatments work. So chemoembolization at the top. Have you got it? Great, thank you. Chemoembolization at the top. Here comes my particle. So this is the blood vessel going to the tumour. Big particle blocks the blood vessel. And what it does is it causes infarction. So it stops oxygen getting to the tumour. The tumour dies through ischemia. And then a bit like if you run something over in your car, you run a squirrel over. I'm not suggesting you go out there to do that, but say you do, and you think, oh, I've got to make sure I hit reverse. Well, that's how this treatment works. You kill it first time by making it ischemic, but then the chemotherapy leaches out, and that gets the bit around the edge of the tumour that you haven't killed with the ischemia, so the penumbra around the edge. Radiation particles are orders of magnitude smaller. So we talk about radioembolization. Embolization meaning blocking tumours. That's a bad term. Actually, what you're doing is just delivering a massive dose of radiation into a tumour. You're not actually causing embolization. So you kill the tumour by virtue of the dose of radiation you deliver to it. So which one should we talk about first? TACE, so transarterial chemioembolization. This is my Hetchins. I've got a 1954 bike. It's got beautiful lugwork. You see I'm slightly obsessed. And we race, I'm going out next week. We raced them in Italy over the old short paths out there. So I think TACE is a bit like my old Hetchins. It's reliable, it's trusty, we know what it does. So I was looking through to find some patients we'd treated with ocular melanoma with TACE. And the first one I could find, there was a lady that came to us a few years ago with a large lump at the top of her liver, 82, so reasonably elderly, but living alone and independent. It wasn't resectable, and we thought it was too big for ablation. So we actually treated her with SIRT initially. So this is my catheter up the aorta, up the big blood vessel, and it comes out into the liver. And you can see here, it's a bit like a tree. This little trunk here is the tumour blood flow, and that blush is the tumour blushing. So a good place to be for me. I can put in my dose, and then we scan people after you've done the treatment, and you can see you've got a load of heat, you've got a load of radiation in the tumour, but not much in the healthy liver. So that's, for me, is a good result. The problem was it treated reasonably well, but then this is what we found with SIRT. Yes, the tumours treat well, but almost always by 9 months a year, the tumours are coming back. So by a year, we were back to the same place. And we didn't know what to do. We went to our MDT and we ummed and ahed. And I suppose based on the fact that we knew that we could get into the tumour well with that angiography, we decided to treat it with TACE. And actually it treated very well. So you can see the enhancement. This was enhancing before, it's sort of greyish. It's gone black. Now, it's black because it's not enhancing. It's not taking up the blood on the scan. So that's, for us, is a good result, and it's starting to shrink. TACE, though, is a bit more morbid than the other treatments. TACE makes you feel pretty lousy for about a week or 10 days. I think it's good for isolated disease. If you have 1 or 2 lumps that you can't resect or ablate, then it's useful. If you've got tumours near critical structures, it can be useful to prevent those from progressing. And there is obviously some interest in the synergy between using an ablative technology alongside immunotherapy. So boosting your immune system just as you kill a tumour with one of these techniques. Although, as we know, we still don't have strong evidence for that in practice. So we don't use TACE very often, and I don't think people should be using it for widespread disease in the liver. So there are papers, lots of papers out there. If you look through, the numbers of patients in the papers are small, as with all ocular melanoma papers. And the survival, I think my take-home message will be about 6 to 9 months is the overall survival in those. There's one, Thomas Vogel's group there with 21 months. But when you look at their paper, it's not normal ocular melanoma. It's people with very small amounts of disease. And you do wonder whether or not they should have been having surgery or ablation or some other treatment. So the next step on our progression, the other tool, or second tool we have in our armory, is radiation. So radiation, Y90 stands for yttrium. That's just the, if you look at the atomic table, that's the particle we're using. It's a beta emitter. So when you go back to A-levels, there was alpha, beta, and gamma. So beta, I see it's a bit like an HGV. It's a heavy particle. It's actually an electron. It's a heavy charged particle. It does a lot of local damage, but doesn't get very far. So if I can put it inside a tumour, it rattles around in there causing damage, but very little of that radiation gets out of patients. Particles are tiny, so that's a human hair. Those are the particles. We put it in 2 settings. You have a workup angiogram where we look at the vasculature of the liver, and then we normally put the dose in a couple of weeks later. So that brings me back to, there's the treatment. That's the box. The radiation is in the box, mainly to protect me and the staff. Tube up through the groin and into the liver. So this brings me back to where we were 6 years ago. I don't know how many of you can remember Leslie. Leslie was a complete guiding star for me in terms of getting me involved in this treatment, and I think actually we owe her a debt of real gratitude. She's moved this field forward more than any other individual. She was tenacious, she was determined, and she wouldn't take no for an answer. I remember she came to see us back in about 2010. She'd had 2 liver resections already, which I think at that time would have been almost unique. And then she'd got recurrence in her liver again, and she said that she wanted to have SIRT. And at the time, we're talking early days for our SIRT practice. Certainly for this indication was the first time. But she convinced us, she showed us the data, she showed us the evidence, and we thought about her case, and it seemed a sensible, practical treatment. So we treated her, and we particularly treated her right lobe because she had a lot of disease there. Right lobe, the tumours resolved, but then she was left with 2 little bits in the other side of her liver. So about 18 months later, she said she wanted those treated, and we used what we call ablation. So have people heard about ablation? Ablation is where you use something a bit like a knitting needle. So basically you put through the skin, into the liver and into the tumour, a probe, and then all you do is heat it up. And you can use different ways. There's microwave ablation or there's radiofrequency ablation, but all they're doing is causing thermal injury. They're causing damage to tissue by heat. And these 2 wedges out of the liver, so there would have been, say, a tumour there, that's taken a wedge out, that's taken a wedge out where those tumours were. She actually had a repeat SIRT, so she had 2 SIRT treatments, so she had a second treatment about 2 years afterwards. So she's the only patient with ocular melanoma, certainly, that's had 2 SIRTs in our practice. But I think we have a debt of gratitude to. She said in Daily Mail articles, only alive because I know how to beat the NHS system. I don't think it was just the NHS system. It was that nihilistic view of most doctors at that time. 6 years ago, people had a fairly negative attitude towards treating people with ocular melanoma and being aggressive, and she wasn't going to take that, and I think full credit to her. Okay, so where's the data? Data sets are small for SIRT. This is from the US, Kennedy's group. Their median survival 12 months. They sometimes use it, in the US, they use it for salvage. So people often have bland embolization first. If that fails, then they have SIRT, so 11 months. The reality is, yes, it undoubtedly stops the progression of tumours, but every person I've treated with SIRT, those tumours come back by 9 months a year. So we can say it's well tolerated, so it's actually a very non-toxic treatment. There are 2 dosed versions, there's glass and there's resin, so that's a technical thing really. You can retreat people, although you have to be careful of that. So we reserve it in our centre for patients that aren't fit for chemosaturation. So chemosaturation involves being put on a bypass machine. If there was a reason that patients are not fit for that, then we would consider using SIRT. So this is the last bit of the talk. This is my Colnago C60. This is my baby. This is my beaut. I'm always worried that my wife will sell this bike for what she thinks it's worth, because it's not what she thinks it's worth, but it does make me very happy. So what I was going to talk about is chemosaturation. So chemosaturation, we know we can get tumours in the liver to respond to chemotherapy. The problem is all the side effects associated with that. So the liver isolation technique has been used by surgeons for ocular melanoma liver metastatic disease for about 2 decades. What you do is you isolate the liver from the body, you give it a massive dose of chemotherapy, then you clean that blood out before you plumb the liver back into the person's circulation. And the surgical technique undoubtedly worked. The problem is, when cancer treatment works, what do we like to say to you? Oh, we need to do it again. So this isn't something you can easily repeat. So that's the limitation of the surgical technique. And then some clever boffins came up with the idea, well, actually, you can isolate the liver using balloons. So what we can do is you can put a balloon up in the heart above the veins of the liver and a balloon in the IVC below the veins of the liver, and that allows you to isolate the blood coming out of the liver. I can then put a catheter up into the artery that's in the blood flow of the liver and inject a drug, which will obviously soak the liver with chemotherapy. And the clever bit is you can then suck the blood that's coming out of the liver with the chemotherapy in it, put it through a filtering system, filter the drug out, and give that blood back to the patient. Now, we shouldn't undersell it. It is still a 2.5-hour procedure. It does involve going on what we call veno-venous bypass. But this is what the setup looks like. So this is a pump that allows the blood to be pumped through the circuit. These are the filters, and there's some bubble traps and things to make sure no air gets into the circuit. This is just giving you a view of what the procedure's like. So this is a tube up the vein, so from the groin vein up into the heart. You blow a balloon up. It's round in the heart because it's unconstrained, but then I pull it down hard and it forms a shape a bit like an acorn, I always think, and that means it's impacted in the top of the veins of the liver. We then blow a balloon up down below, and what that's doing is that's isolating all the blood coming out of the liver. And I can prove that because I can turn the circuit off and I inject contrast X-ray dye, and what it's doing is it's filling all the veins of the liver, but none of that is leaking out into the heart or anywhere else. So I've isolated the veins of the liver at that stage. What we then do is we then put the blood so the blood is actually going through these filters, those carbon filters. That's to allow us to clean the blood, and then we inject the drug. So what do we do at Southampton? Yes, we have an we've got an ocular melanoma MDT, which just looks for ocular melanoma liver mets. We run that every other week. Every patient coming through gets worked up for this treatment with a Primavist MR. So I think no arguments at that stage. You want to see the extent of the disease. We do a CT chest, abdomen, pelvis to look and see if there's extrahepatic disease. I think that's very important to know. And we consider doing laparoscopy and liver biopsy. As we've said, having tissue is a really critical bit of this in terms of our understanding of tumour biology. The other advantage of laparoscopy is sometimes when surgeons look inside, the liver's much more extensively involved than we're seeing on imaging. We won't go into the ins and outs of how we deliver the treatment, but I think one of the important things we've learned is you need to work patients up well for their individual risk of having this treatment. So we use some special anaesthetic tests to see how fit patients are, cardiopulmonary tests. I think we're the only centre to do that. And the drug is actually mustard gas. It's actually melphalan. It's an alkylating agent. It's a drug which kills tumours, whatever tumours are doing. So it's quite an old-fashioned drug. But seems to be very effective in this setting. And part of the reason for that is the liver doesn't seem to care about it. So the liver's unaffected by it, but it's very good at killing tumours, whatever part of the cell cycle they're in. Patients used to go to intensive care. They now just go to surgical recovery. And most patients are discharged at 72 hours. So where's the data? Well, this is where we struggle. The original trial, so the trial data is about 10 years old now. They randomized patients, 93. Now, some of these had cutaneous melanoma. They weren't all ocular melanoma. And they either had the treatment or they had best alternative care. One of the problems, though, and this is the weakness of the trial, is over half of the ones that didn't have the treatment went on to have the treatment. So they were allowed to cross over. So when they progress, so patients that didn't have Delcath, when they progress, when their liver got worse, then they were allowed to have Delcath. And that makes it much harder to compare those two groups because obviously the one in this arm, half of them have ended up having the treatment. What the trial did show us is the treatment works in controlling liver disease. So there's a big difference if you look in terms of hepatic progression, so liver progression. So 1.6 months in those that didn't, 8 months patients that did. So it's making a difference to liver tumour, which is all you can expect a liver treatment to do. The problem was, when you look at the data, there are a lot of patients having fairly significant complications associated with this treatment. So it went to the FDA back in 2013. This is the American advisory board. And they said, well, actually, yeah, the treatment is effective, but it's toxic. You're doing harm to patients by delivering this treatment. You haven't demonstrated well enough to us that this is a safe treatment which is a benefit to patients. And this has really held us back. And the reason it's held us back is I think patients who were recruited to that trial, they were being done in centres that only done a few cases. Now, it's a bit like surgery or cookery or whatever you want. You know, the second time you make, I don't know, lemon souffle or something, you don't bring it out at a dinner party. You make sure you've worked out how to do it. You know, if you're doing a big operation like a liver transplant, you don't do your second case and then think that'll be a good time to test this against some other technology. You learn how to do it and do it well, and then you test it. And I think that's really hampered us in terms of getting commissioning for this service. And this is David Brailsford, so love him or hate him. Chris Froome, you will recognise him? Won the Tour this year and the Vuelta this year. So what does Sky Team believe in? They believe in marginal gains. They believe in this idea that you make lots of little changes. And I believe that as well. So they make little changes like, sounds ridiculous, the bike computer, bringing it back a centimetre so there's less turbulence in the wind. This year they're accused of cheating because their cycling suits have lots of little bubbles on them, which is said to improve airflow across them. But that obsession to detail is what's important. And that's what we've focused on in Southampton. So we've done the most in the world of these. We've done about 130 now. And I've been the primary operator with the same cardiac and intensive care anaesthetist, same cardiac perfusionist. And yeah, when we started, 6, 7 years ago, we were really just getting to grips with this. But each one of us, each part of our pathway, we've got better and better at. That's my perception. The early data, first 50 patients, first 115 treatments, reasonably good overall survival out towards 2 years. Now, the early days, we were only treating patients once or twice a year. Now, in the trial, we're doing 6 treatments, 6 weeks apart, so much more intensive treatments. I was worried about how patients would tolerate that, but the people in the active arm of our trial have tolerated it well, and we're getting some very, very good results in terms of outcome. What we need is that data to mature, and with the numbers so we can publish it and then get it out there as a treatment which is available to people. This is one of these waterfall plots which shows, so basically you scan someone at baseline, you work out the volume of their tumours, and then you scan them later and you work out have their tumours got smaller or have they got bigger, and each one is an individual. There's some in the middle which I think we couldn't assess because their reference lesion was less than a centimetre. But that shows you that the majority of people get a significant disease response from the treatment.
Those complete responses on the end?
Yeah.
So 100%
yeah. Is it without toxicity? No. So the complications fall into 2 groups. They're either technical issues, which are actually much less common now. So early on, we had one person that had pulmonary edema because we gave them too much fluid. One person that had a tachycardia during their treatment, which stopped when we stopped the treatment. We were able to treat them. And one vascular complication, which is a plumbing problem. You're making holes in people's vessels, and you're going to get bruises and complications. The hematological complications, we seem to see much less. And I think that's because we're getting a better seal, and we're also running the treatment much faster when the filter's much more efficient. So actually, yes, we do give people pegfilgrastim, which is a drug to boost their bone marrow, but actually neutropenic or neutropenic sepsis is very uncommon now. And we treat lots of international patients. So I think the last I've treated one this Tuesday. There's a woman who came from Florida, 32, 33-year-old mum. She was discharged yesterday morning, so less than 48 hours she went home. She wanted to go and see Stonehenge before she flew home, and she's flying home tomorrow morning. And that's her 3rd treatment. So she knew what to expect when she came over. And I think that shows how well the treatments are tolerated now, relative to when we started the pathway. So what do we imagine in terms of how does liver-directed therapies fit into the pathway? So the first thing is to pick up disease early. And I have no doubt that liver MR is critical to that. We can argue about the contrast bit. Liver-directed management is all about buying time. It's about controlling that burden of liver disease and then looking at whether or not we can find a systemic treatment which feeds into that, whether immunotherapy combined with liver-directed therapy or one of the newer agents fitted in with liver-directed therapy will be where we're going. If you don't control the liver disease, we've shown throughout all the trials, you don't get control of this disease. And now we've talked enough about systemic treatments. So this is us, London to Paris last year, 70 of us with our patients. We cycled it in 24 hours, so that's 330 kilometers in 24 hours. Fair old feat. So there's our ocular melanoma team. So the brains, top there's like David Brailsford at the top there, just watching down and thinking, what are they up to? Matthew Wheatier, medical oncologist with an interest in ocular melanoma, having his legs waxed. That's really extreme. Neil and me out in Paris. Neil bought the champagne, which I then sprayed over all the patients above. And she's probably the most important person there. She doesn't wear that at work, I'd hasten to add. Lisa, so she's our interventional oncology nurse specialist. So she's the person that manages people as they go through our pathways, keeps an eye on them, manages their expectation. The trick to this is having a team that can offer you more than just one technique. They can offer you the breadth of techniques, whether they're surgical, ablative, liver-directed, immunotherapy, trials. You want a centre that can offer you all of those things, and then they chose the most appropriate treatment for you. Now, I'm sure this is how you feel at the end of this, completely overloaded. I'm not going to test you all out. What I hope is that interventional oncology is a new field. Up till now, medical oncologists, so chemotherapy oncologists, surgical oncologists, people like Neil, people with scalpels, and radiation oncologists, people who use radiation to control tumours. But I think there's a little area here for interventional oncology. Our ability to isolate organs, to treat organs according to their anatomy, and direct treatments, and therefore harness the power of the treatment in the area where the tumour is, has real merit and real benefit to patients. And I hope we're going to start to accrue the data to prove that, and then we can get these treatments commissioned. Thank you.
Thank you very much, Brian. Questions, please? Yes.
Can I just ask, you mentioned during the talk that you thought that prior radiation therapy could enhance systemic response to immunotherapy drugs. Anecdotally, have you seen much evidence of that?
There are all these wonderful case reports, aren't there? And there are some animal models looking at just that, the idea that by destroying tumour and presenting antigen at the same time as you upregulate someone's immune response, you can actually see a benefit to that. In terms of hard clinical data, we're still looking for that. There are trials out there looking for that. I'm sure the clue to this will be, ocular melanoma is an odd disease that the burden of liver disease is the dominant thing. The clue to this is to control the liver disease and then find a systemic therapy which is effective. Now, which combination of the different treatments that will be, sadly, no one knows at the moment.
Next question.
It's not a question, it's a comment. My dad had treatment for that cancer and he had a complete response. And he had a complete response. So I suppose we're at the stage now where we're thinking if immunotherapy is needed, we're sort of exactly at that stage. So hopefully we've had some very good treatment from Southampton guidance and very good communication from Southampton to the local oncologist in Dublin, and I just want to, I suppose, thank you for that. Thank you.
Always happy to take comments like that. Can we have a question over there, please?
Having looked at all that, looked at it for myself, the stumbling block is the cost.
Yes.
I know there's a trial, but then there's only 50% of the people that get it.
Yes.
Most insurance companies won't touch it.
Yeah.
So how close would you say you are to getting this to the point where, regular Joe can have it?
I think there are two bits to that. I mean, this is a new novel technology. There are two bits to that. First of all, we need to work on driving the cost down for the therapy. So by not using intensive care, by discharging people 2 days after treatment or the day after treatment, all of those things are important. The company, in terms of reducing the cost of the product, now that happens when we start to use it more widely, because these things are just balances of, if you're only selling 3 cars, you need to charge more than if you're selling 30 cars or 300 cars. And then we really need that focus study. We need the trial data to show that without doubt, this offers people the opportunity of significant improvement in survival with quality of life. So quality of life is the other important bit about ChemoSat. It actually has very little impact on people's quality of life. People come in, yes, 2 days later they're going off to Stonehenge or somewhere else. That's the other bit of the equation, because there are some cancer treatments which offer you prolongation of your life, but a significant cost in terms of side effects. If I'm honest, though, we're a few years off having this routinely commissioned as a mainstream treatment.
So with the FOCUS trial, there's like 30 patients worldwide or something being randomised, is that right?
At the moment, I think you're about right there, yes,
Yeah.
in the US,
And are you getting many referred in from around the UK?
Yes, the problem we have is capacity. So because it's quite intensive, it's 6 treatments, 6 weeks apart. At the moment in our university hospital, we struggle to do more than 1 a week. So it's a bit like landing planes, isn't it? That the recruitment people come in sort of a little burst, don't they? You suddenly find 3 people are wanting to get onto the trial, and it's a matter of making sure that we have capacity to deliver that. There are other centres in the UK about to open up, and hopefully that will improve the situation.
Good. Question, Sarah?
Yeah.
Just wondering whether you considered taking biopsies of the liver mets
Yes.
from the patients under treatment. And particularly those who haven't responded, to understand why they haven't responded.
Yes, we hadn't, oddly. I think we've got tissue from people that have responded. I'm not sure, actually, whether we've ever got tissue from non-responders. I mean, it's easy to stand up here and be completely biased. This is my baby, this is what I believe in. Actually, non-responders are a fairly small group in our treatment. I have to look at Christian because he's honest. But, I mean, actually, non-response is actually unusual with this treatment. There have been people who've got on well with the treatment with neutropenia and other things, and therefore they've dropped off. But actually treatment, I'm thinking there's probably 1 or 2 patients out of all the patients we've seen, 120 treatments that have progressed despite treatment.
You showed that
Yes.
And then you went in with FIP.
Yes.
So just trying to understand the biology of
Yes.
the melanoma cells.
Yeah.
Is a particular clone pushing through?
Yes.
Or, is it encircled by, I don't know, fibrous tissue?
Yes.
What is stopping the drug getting into the tumour and actually eradicating?
So this is anecdotal, but almost undoubtedly looking at our MDT, when we get recurrence and progression, it's almost always new disease. I'm thinking we saw 2 at the MDT this week. Actually new clones of tumours seem to develop. Sometimes in the same segment as the liver, but there definitely seem to be new clones that develop. And sometimes can be quite aggressive. They can be quite different from the original population of tumours. But yes, without tissue, we're not going to answer this, are we?
Yeah, I think something that you're alluding to here as well is the different patterns of disease that we see. We see some patients who present with the measles, as you've described, liver-only disease, but very diffuse, who seem to respond less well. We see another group who get liver-only disease, but with more isolated nodules who seem to treat particularly well. And then we see those who also get the extrahepatic disease, the disease dotted around. And a group of them are oligometastatic, which is that lots of nice rounded, isolated, bigger lumps. And they actually do quite well with lots of aggressive treatment for those lumps, cherry picking. So they're the ones that sometimes we do unusual patterns of surgery for. We've got one lady who's going for nearly 5 years now, who presented with ovarian secondaries. So she ended up having ovary out in a hysterectomy. Then she's had 2 rounds of liver surgery about a year later, 18 months later. And she's also had a pancreas out, which was about 9 months ago. And she is alive and kicking and still on the rugby touchlines and doing all that stuff. So there are odd patterns of disease, and as well as looking to put people in trials and so on, it's that occasionally looking and saying, right, this person's a bit different. How can we manage this patient holistically in terms of the pattern of disease they're presenting with? More questions and then lunch. Go, Christian.
Really a comment. I think the pattern of what happens if you control the liver disease has changed in our practice. So where in the past we saw patients whose liver was filled with cancer and they were imminently dying often when they came to us. And we're catching that group of patients early. So a bit of doing better may simply be because we're seeing patients who are well rather than those who are already at a point where there's no further option. I do think also, however, that controlling the liver disease, in our data set, I think it is clear that if you control the liver disease, people live for longer. So the life-threatening disease in our cohort seems to be the liver disease. But if you control the liver disease with a local treatment, then you're also beginning to reveal what else might be happening. So the systemic disease that Paul was talking about earlier on, I think becomes visible in part because we're now better at preventing people from dying of their liver disease. So I think it highlights that liver-directed treatment does prolong life, but doesn't solve the problem of cancer. But I think that's a great step in the right direction. If you're alive, to be able to live and to see another day. And the real problem then is that we haven't solved the underlying principle of what we should do about human melanoma. I think that's really where all the presentations today have concluded that we need to understand better how we should at least begin to unravel these puzzles so that we can make rational decisions.
Thank you all very much. So I'm going to draw this session to a close now. I'm really grateful to our 4 speakers. I think it's been another fantastic session, as good as any we've ever had here. And I think it shows the challenge, but it shows real promise for the future. So now let's see what the lunch promises for the future. And I look forward to seeing you this afternoon. Thank you very much.